Yes, good afternoon, everyone that has joined this call. Thank you so much for sparing your time to come and learn more about mental health. This workshop is majorly for educators and parents. Educators, those are the teachers and other members within the education sector, but also other sectors that handle or work with people. In today's session, we shall have an opening prayer, and then we shall have some simple introduction. In case Mrs. Patience is on, she will say something, and then after, we shall have our presentation from Mr. Chimboa, and then those who may have some questions, we shall use that time to ask the questions, and then lastly, we shall have the closing remarks. May I invite any volunteer who wants to lead us in a word of prayer to raise up the hand, and then you take us through the word of prayer. Any volunteer who wants to lead us in a word of prayer? Yes, Abe, you can go on. Yes, sorry. Any volunteer who wants to lead us in a word of prayer? You can raise up your hand and then you lead us. Okay, yes, Ruth?
Hello, sorry, this is Ruthie's parent, but we can pray together.
Okay.
Father in heaven, we want to thank you for this afternoon. We thank you for this meeting and the people that are joining us on the call later. We also want to dedicate our facilitator in your hands. We pray that, Lord, whatever we shall learn will nourish our bodies and be able to impart and impact others for a positive change. In Jesus' name we pray.
Amen. Thank you so much, Dad Ruth, for the word of prayer. Our session today, we are going to have a discussion on understanding the student mental health. Some few weeks back, we shared an article on one of the cases we found in one of the schools, and that one triggered us to hold this session. So we thought it wise that if we come together online, we can share a lot on issues concerning mental health. Our children in school and the different institutions of learning are undergoing a lot of things, but many times we may not be able to recognize the signals, and sometimes we may find it late that these children are really struggling with one thing or the other. So this session is going to enable us to discover what are some of those mental issues that we may need to look out for, what are some of those signs, and how best can we support the children, both when they are at school and when they are at home. So that is one of the major intentions for this session. And we are very sure that by the end of the session, many of you'll have learned something from the session. And for those who may have questions, please feel free to ask the questions through the chat, but also at the end of the presentation, we shall have a session and a question and answer session whereby you can ask in case there is any concern that you have been able to identify within your school, and maybe Mr. Samuel has not been able to talk about it, then you can come in to ask that particular question and you will be able to say something about it. So that is our major objective for this session. And I'm going to ask those who can, you can type in the chat. You can type in the chat some of your questions, but also you may let us know where you are connecting from. So this session is going to be an eye-opener, and we shall share the recording at the end of the session. I want to just be sure whether this is Mrs. Patience Quizela.
Oh, yes, it is. Just Steven. Good afternoon, everyone.
Good afternoon. Okay. Yes, you are most welcome, Mrs. Patience. And allow me to invite you to say something before we start off with the presentation from Mr. Samuel. You're most welcome.
Thank you, Teacher Stephen, and good afternoon, everyone. My name is Patience Butesi Kwizera, like he has said, and I'm glad to be here. And I'm especially grateful to you, Mr. Stephen. What you're doing is incredible. Thank you very much for putting our children's mental health at the forefront. I see it began as a simple thing, but I can see you're taking it a step higher. Please keep it up, because we all know that mental health is the beginning of everything. And especially if we work on it when the children are still young, the age at which they are, they really need guidance. They need to work on themselves when they are still young, because in most cases we see people, grown-ups, struggling with things. But when we dig deeper, we identify that these things started way back when they were still young. So I believe what you're doing right now is very, very important, because we are dealing with the mental health at the beginning, before it gets out of hand. We need to work on our well-being instead of working on the illness when it has escalated. I also want to appreciate Samuel. Samuel is a colleague, but I really, really appreciate you, because what you're doing, only God can pay you back. Thank you for always being available and for stepping in, because at the time when I called on to you, I didn't have time, but I knew you are capable, and you have done it very well. Please keep it up. Wouldn't want to take a lot of time, because these are timed things. Thank you, Teacher Stephen. Thank you, everyone, for logging in, and I hope the message will get to the children. Thank you.
Thank you, Mrs. Patience. And allow me also to thank you so much for pioneering this initiative. And thank you so much for all the support that you are really offering. It is because of you that we are able to get to Mr. Samuel to do for us these sessions. Our facilitator today is a child and an adolescent mental health specialist. Mr. Samuel also does psychosocial support and is a facilitator in that field, but also is a psychological first aid provider, is a public health promoter, community psychologist, but also a senior occupational therapist. Is a community trainer and researcher, and these are his contacts where we can be able to reach. Allow me now to welcome Mr. Samuel to start off the session. Mr. Samuel, you're most welcome.
Okay, good afternoon, everyone. Thank you, Stephen, for this opportunity. And I would also want to thank Patience for linking me up so that we can blow the trumpet of mental health higher and higher. We preach the gospel about mental health so that people can be able to understand how to protect their mental health, but as well as seek for help when they are troubled in one way or another. I would also like to thank Stephen for this opportunity to speak to the bigger audience, but also spaces where most of the children go to, because we see that almost 80% of a child's life, those who are school going, is spent within the school. So it is important for us also to disseminate this information to educators, but also the parents who have tuned in, so that they can understand that mental health if not properly cared for, can affect a child's social, academic functioning, and other areas of life. So thank you very much for this opportunity. For those who do not know me, I think I can switch on my camera. This is how I look like. You saw the picture there. I think now we can begin. Maybe Stephen can share the slides so that we can start off. So our theme today is, of course, mental health among children and adolescents. Like they have introduced me, I'm a mental health worker. Mental health is my area, is my passion. I breathe mental health. I do mental health. So in different areas. So let's continue. So today we want to us to understand concepts used in mental health. What are those common definitions or terminologies that we usually talk about in mental health? But we want also to learn things that can put our young people at risk, as well as those that can protect them from mental health problems. But also want to go through the different types of mental health problems. But also we shall have a discussion as we go on how educators, but also in this case, parents who have tuned in, how we can support young people who have mental health problems, but also those who are at risk of having them. How can we protect them from having that? Yeah, thank you. Next slide. Yeah, so when we look at mental health components, I usually prefer from starting with health. Health itself, mental health is part of health. You cannot say I'm healthy when your mental health is down, okay? So health is usually defined as a complete state of physical, mental, and social well-being. So physically, you are healthy, mentally, in a mind, but also socially, the way you relate with others. So health does not mean that if I don't have a disease, it does not mean that you're healthy. Some of us, we go through stressors, but we don't have what? A disease. And that may contribute to some poor health and so on. So, and we say that it is a resource for everyday life. If you have poor health, it's going to affect your day-to-day living. So it is a resource. Okay? And it is a positive concept that emphasizes our social and personal resources as well as our capabilities. So when you look at health, you can look at physical well-being, mental well-being, and then social well-being of an individual. Continue. Now from health, we take out mental health, which is our point of discussion today. And we can define mental health as a state of mental well-being, and that enables people to cope with stressors of life. We all go through stress, but in mental health, we look at, are you able to cope up with stressors of life? For learners, it might be academic work. For teachers or parents, it can be the day-to-day work that we do. Like for teachers is how we organize and prepare to mentor learners. For parents is how do we take care of our learners, look for tuition or school fees, and take care of them in different ways. And other stressors of life. So we can, but also mental health can look at how we learn and work well and how we contribute to our communities. So if you can cope up with stress, if you can realize your abilities, you can learn well and work well and do something that benefits your community. That's what we look at as mental health, okay? And like I've said, it's an integral component of health and well-being, okay? So here you tackle normal difficulties of life. Are you aware of your abilities? Can you work productively? Are you able to contribute to your community? So that is what we call mental health. Next. Now from mental health, we have what we call a mental condition. Some people call it mental illness. A mental condition or illness, this is a broad term covering mental health problems and psychosocial disabilities or problems. So it can cover other mental states associated with stress. If I have a lot of stress, that can impair my functioning or can put me at a risk of suicide or self-harm. For example, if maybe you lost company money as a parent and it's a huge amount of money, that stress there can put you at risk of self-harm or suicide. So that's what we look at as mental health. And then there are stages from mild to even severe symptoms that can affect day-to-day functioning. Continue. Now, again, we have what we call a mental disorder. The word disorder means something that disorganizes your order of life, okay? That's why we call it disorder. It puts something out of order. So this is a group of symptoms. That's why we call it a syndrome. That are characterized by disturbance in the way you think, that is cognition, the way you regulate your emotions or behavior. And usually, people are going to be affected in their functioning, in their psychological, biological, or even as a child, the way they develop. And this later on is going to affect your functioning. And these disturbances are normally associated with distress or stress or impairment in personal, your family, social, academic life, work, or other important areas of functioning. So a mental disorder is an umbrella, but under it, as you see, there are so many conditions that can affect an individual. Yeah, so continue. So we want to look at what are those things that determine our mental health. So our mental health differs greatly depending on circumstances in which we are brought up, raised, or live, where we live daily in our lives. So some people live in stressful environments, others live in rural, others live in urban, and these environments and the way we are raised and parented determines a lot the outcomes of our mental health or well-being. Okay? This is because mental health is determined by an interplay of so many factors. This could be personal factors or individual, the family in which you grow in, the community you stay in, the way the structures, the way it is made up, buildings, the environment, the spaces in between. And these ones are different from one individual to another. Someone who lives in Kololo, for example, in Kampala is very different from one who lives in Katwe, in the ghetto. So these factors can influence our mental health and well-being. And usually when individual vulnerabilities interact with stressors, they can lead to mental health conditions. The more you get stress and you are vulnerable as an individual, you are more likely to get a mental health condition. As you've seen in the diagram, that the more you are vulnerable, as the stress increases, you are more likely to have a mental health issue. Continue. Next slide. Okay, now we need to also to understand what puts us at risk of mental health issues. What are those things that would also protect us from having mental health issues? So here we've broken down individual, family, and the community, but also structural factors. So we have protective factors. These ones improve or enhance our mental health. For individual, we have genetics, or genetic factors. Some of mental health problems run in families, okay? They follow a bloodline and move on from one generation to the next. Then we have social and emotional skills. If you have good emotional and social skills, you can regulate your emotions well. You are a person who is very social, you have friends, you have a support system, then it can put you into good mental health. Then if you have a sense of self-worth and mastery, you know what you want in life, you know what you're good at, you have a high self-esteem, okay? That can also protect your mental health. Then good physical activity, exercise, okay, is very important for our mental health. And that's why even in schools, we urge young people to engage in some kind of sports, okay? So even us as educators and parents, it's very good to enter into physical activity and do exercise. But also if you have good physical health, if you don't have any other medical problem, that is a protective factor that can put you in a good place not to have mental health issues. Then we have family and community, good perinatal nutrition. As a child, if you were fed well, as you grew, that one can also be a good factor, especially among children and adolescents. Good parenting, parenting style. We are brought up differently, but some parenting styles can protect us from mental health problems, but other parenting styles can be very detrimental to our mental health. So, but here we look at good parenting. Then physical security and safety. If where we are, there is security, people don't break into our houses, there are no wars, there's no ethnic violence, basically that will be a good protector of our mental health. Then positive social networks, social capital and social support. If you have a social support network, friends, family, people, you subscribe to different social groups that can protect you. Then green spaces, of course, where people have a lot of trees and good environment that can also protect them. Then structure, we have economic security. Of course, we know that having man on you lessens stress, okay? As we shall see later on, that there is a vicious cycle between poverty and mental health. Then good quality infrastructure in terms of housing, where we stay. If you have a good home, there is no overcrowding and so on, it can also protect us. Then equal access to services, if people can have all the services, irrespective of the different things that maybe separate us, like age, beliefs, culture, and so on. If we can have access, it can protect us. Then quality natural environment, breathing good air, and so on. We have vegetation and the green. Then we have social justice and integration. If there is no stigma in the community, there is no prejudice and bias against different tribal or ethnic minorities, this can affect us. I mean, this can be a good protector. Then income and social protection. Of course, if we talked about the economic security, if a home is able to have some level of income or society, and there is social protection of in that society, then it can protect our mental health. And then social and gender equality. Those are some of the protectors. Next slide. Then we have factors, risk factors in family, community, and structure. These ones undermine our mental health. Of course, we talked about genetics. If there is no history of mental illness in the family, the chances are higher, like we saw in a protective. But here, we see that if there is history, then this puts you at a risk as an individual. Then low education, people who may not be well educated. This can come from people not maybe engaging in risk-taking behaviors that can undermine their mental health. Maybe not seeking a treatment when they are sick. Maybe where they go, they can go maybe to traditional healers instead of hospitals. That can affect our mental health. Then alcohol and drug use is a lot, which is rampant nowadays among our youth. Unhealthy diet, eating poorly, foods that don't contain the essential vitamins and minerals, obesity and other metabolic risks. There are these non-communicable diseases, high blood pressure. If they are there, then that can put us at risk. Any chronic disease these days, it is associated with some mental health like depression and anxiety. Vitamin D deficiency, which is very important. We need to go and get some sun. For those who work in buildings, these days they even supplement with vitamin D tablets. Then if you are not satisfied with the way you look, body dissatisfaction, that can, especially among adolescents, that is going to cause a lot of problems. Then sleep disturbances, if you struggle with sleeping, that is going to affect your mental health. Then obstetric complications at birth. If as a child gets complications during birth, they are more likely to suffer a mental health problem. Then at family, we have, if someone has ever had sexual abuse and violence, then emotional and physical abuse and neglect, then substance abuse by mother during pregnancy, then bullying the young person, intimate partner violence, being a war veteran, especially in our communities now, Uganda is very open country to refugees. So those who have survived the war and they come to our communities, they are more likely to suffer from mental health problems. Then sudden loss of a loved one, a parent, a guardian, any significant loss of a loved one. Then job strain, job loss and unemployment. Job strain is those who work in jobs that have a lot of stress and pressure, they are more likely to suffer from mental health problems. Then living in an urban setting, why is it a risk? Sometimes there's a lot of noise. Every service that you have to get has to part away with money. And if you don't have enough money, that can put you at risk, but also the pressure that people face in urban settings. Being from an ethnic minority, if you are a person who is from ethnic minority, you're more likely to be stigmatized or sidelined, and this can affect you. Then structural risks are climate crisis, pollution or environmental degradation, poor quality infrastructures, poor access to services, injustice, discrimination and social exclusion, socioeconomic and gender inequalities, conflict and forced displacement, and then health emergencies like COVID. Initially, we've had Ebola, we've had monkeypox. If these emergencies are there and affect people, it's going to result into mental health issues. Continue. Next slide. Now, this is what we call the vicious cycle of disadvantage, and where poverty and where we find a lot of poverty, we are more likely to find mental ill health. Okay. Sometimes we have, if you grow in an environment where we say poor parenting, including harsh punishment and neglect, poor educational attainment and school failure, domestic and interpersonal violence, reduced livelihoods, mental health conditions, alcohol and drug abuse, risk-taking behaviors, including self-harm. So people are going to be in that vicious cycle of poverty and ill mental health. And they are going to struggle if interventions are not really done. Yeah, so this one shows you the relationship between poverty and mental health issues. Continue. Then how common and widespread are mental disorders? Mental disorders are widespread, but they are one of the undertreated and under-resourced. Okay? Widespread means is globally 1 in 8 who live with a mental health condition in their lifetime. Undertreated, 71% of people with psychosis, which is a mental health problem, do not receive mental health services. Under-resourced, when you look at budgeting for health problems, mental health is one of the least poorly funded health issue, okay, in the health sector. Yes, continue. Then we have how widespread are they? I'm going to use the global statistics so that we see them. These are from World Health Organization. If you look at these statistics, 970 million people living with mental disorders. And then we have more females than males. Then we have anxiety and depression are the most common mental disorders worldwide. Then closely in there, we have developmental problems in children, but then we have others follow like attention deficit, bipolar conduct, autism, schizophrenia. But when you look at in low-income countries, the statistics are much lower, and the reason could be that it is due to being detection, whereas in high-income countries, it is higher because they quickly detect some of these problems, but also they keep records, which is not the case in what? In low-income countries. Although we see here on our key that low-income countries have a lower prevalence or widespread, it does not mean that it is really low. It means that data is not captured. People do not go to hospitals to get treatment. Yeah, but the picture is it should be even higher than even in high-income countries. Continue. So across regions, if you look at globally across regions, of course, this is what it means that in America and Europe, it is higher, but I said due to detection. And then mental disorders, there's what we call premature mortality for mental disorders. People with severe mental health conditions die 10 to 20 years earlier than the general population. Mental illness does not kill itself, but the effects of it, you die a bit younger than people in the general population. And that is why we are here today to talk about it. So in case there are measures to prevent, we can, but in case people are affected, then we see how we can help them so that we increase life expectancy. Continue. Then suicide and self-harm. Suicide accounts for 1 in every 100 deaths globally. And you can see that suicide happened before, 58%, which means a big percentage of people who commit suicide are below the age of 50. And by 2019, 7,003 people had died of suicide. And if you look at in low and middle income countries, suicide is on the high rate, okay? And actually, if you look at the years, beginning from adolescence, from age 10 to around age, maybe age around 50, suicide is really at the high peak, which means youth and young adults are more likely to commit suicide than the seniors, okay? Yes. Let's continue. I'll still talk about COVID-19 because we still have the effects of COVID-19 up to today, okay? Yes, because it affected the whole globe. People died, people lost their livelihoods. Actually, many people have not recovered. Families still up to now are still having effects. We are strained, separated. Many children, though they recovered, but their learning and socializing was disrupted, which is very important for their development, especially young children. Many businesses, of course, closed, others went bankrupt, poverty set in. People became more anxious, okay? Yes, so during COVID and after COVID, when the lockdowns were eased, we saw an influx of people, so many people seeking mental health treatments or interventions. Yeah, so that's why the effects of COVID-19, and people still are grappling with them up to today. So let's continue. Mental health services were severely disrupted, which means even during the COVID situation, you couldn't access mental health services. Of course, even us who work in mental health, sometimes we are redeployed to work to the epidemic of COVID-19. So we did not really stand there and wait for our patients, but we had to go and support. Of course, people in some places were more affected than others, especially those in urban settings. Okay. Yes, so many people reported many health problems, resulting to negative coping strategies to deal with distress. Let's continue. Next slide. I'm going to look at what are the barriers to seek for mental health care. Of course, the extremely high unmet need for mental health care among people with severe mental illness is due to lack of demand or uptake of services. So there's this reluctance or inability to seek help can be explained by a variety of factors, which is high cost, poor quality, and limited accessibility. So even if people are to access care, some places in the country, the services are hard to access, but also they may not be of a high quality, but also the cost of maybe transport, the cost sometimes if it's in private practice of seeing a specialist might be quite higher. Then there is lack of knowledge about mental health. This is very, very common. Even among the educated, many people don't have knowledge about mental health, and therefore they are more likely to grapple with the conditions when it affects them or their family members. Then there is stigma and poor previous experiences with seeking help. Okay? Yes. So people fear if I come out and say that I have mental illness, they're going to stigmatize me, they're going to point fingers at me. So people keep quiet and then they suffer silently. Okay? But also sometimes when people try to seek for help, they may not get the needed help that they really wanted. And therefore, they rather not do what? They rather not seek for some help in some places, like in some health facilities, due to inadequate supply of medicines, people might desist from going there because obviously they may not sometimes go when a medicine is available. So they turn to traditional healers. Sometimes they turn to religious people for support. Continue. Now, what are some of the common mental health problems or disorders? I use the term disorders because it disorganizes someone's way of life or the order of life. So what is anxiety? Anxiety, I can simply talk about it as a fear of something. Okay? Some people fear failure, people fear bad news. Some people might worry or have anxiety about financial difficulties, shyness, dramatic events. But what are the symptoms of anxiety? Some people are going to have sleep problems, low concentration. If this is a learner, then you start to see drop in academic performance, then increased heart rate, someone always having palpitations, fearfulness, sweating. So this anxiety is one of the most common problems among our learners due to certain reasons. But treatment is available. One, if you can encourage them to talk about their fears through communication with trusted people, positive thinking, some of the fears are just in people's minds, but we can encourage them to think positively. Then they can have psychotherapy where someone goes to see a psychologist, a counselor, or any other mental health worker to help them process and work through their challenges. Then physical activity or exercise can help someone to cope up with anxiety, and then meditation, okay? Or even prayer can help us to cope up with anxiety. Next slide. There are so many types of anxiety, but we have generalized anxiety. People who worry about almost everything. That's why we call it general. Then panic. Panic disorder, where someone is hit by a quick experience of terror, severe fear, where they even tremble and have difficulties to breathe, okay? Like they say, someone has had a panic attack. Then we have obsessive compulsive disorder, people who have repeated obsessions and compulsions, okay? Someone is too clean for life, okay? Someone has different repetitive behaviors. They want to be orderly. They want to be so keen on things, okay? It can affect, so there's a fear for germs or that. Then social anxiety, people who fear public places. Sometimes we may classify them as being shy. And then people who have specific fears for phobias, fear of a specific situation or object that may rather be harmless, but people might have. Maybe someone extremely fears a rabbit, but a rabbit is never hurt. Some of us ladies, we extremely fear a cockroach or a caterpillar, but a caterpillar has never killed someone in history. But we have very severe fear, okay, for some of these things. And then we have trauma. Nowadays, it has been now revised, but usually it used to be called classified under anxiety, where someone has had a near-death experience or has witnessed people dying. You witness or you be part of it, but you survive, okay? So those memories can be quite traumatizing, can be quite upsetting, and they trigger a lot of fear and anxiety. Next slide. Then we have depression. Depression is one of the most common symptoms among people, but also it's very common among our learners. It can present as sadness, but sadness that is persistent. A young learner may lack energy, may fail to eat, may start to isolate themselves. They are going to have sleep problems. They are going to be easily angered, and sometimes they lack concentration. And if this is a learner, there is a drop in academic functioning. And depression affects almost 50 to 80% of people. So what are the treatments? Sometimes you may need to take some medicines like antidepressants. It's sometimes good to rest enough, to have enough rest. Some people even take vitamins, because when the body lacks vitamins, it may not function well. But then you need to see a doctor, or in this case, in mental health, we call them psychiatrists. Then you have to have a health diet, eat well, okay? Foods that are able to provide you with a balanced diet, then positive thoughts, okay? That this can help you to alleviate depression, because negative thoughts always put down our mood and we end up feeling sad or depressed. Next slide. Of course, these are the common presentation of depression: multiple persistent physical symptoms with no clear cause. If someone says, I have this pain here, there, and especially young people that have no cause, one of the things we should think about is depression. Low energy, significant change in appetite or weight. So someone might gain or lose weight, or they might eat a lot more than usual, or they lose appetite. People believe that they are worthless. They feel they are guilty, that maybe they are to blame for what is happening. They are not decided on things. They are restless or agitated, and then they lose hope in life. And at this point, they are going to think about committing suicide, okay? They think, but also they may attempt to commit suicide. Next slide. Then somatic complaints in youth. The word somatic comes from the word body, soma, meaning body. By definition, they involve psychological stress manifesting as physical complaints. Someone has stress, but they're going to complain of headache, they're going to complain of joint pains, they're going to complain of chest pain, stomach ache, okay? So we use sometimes the word conversion disorders, that the stress has converted into a body symptom or ailment that someone has. Some people are going to have what we call psychological or what we call psychogenic non-epileptic seizure. Someone falls down and begin jerking as someone who has epilepsy, okay? And this can impair academic and social functioning. Sometimes we used to call these conditions, someone has hysteria, okay? But now the term has changed. We call them somatic complaints. And then we have psychogenic non-epileptic seizures account for 20 to 40% of cases in epilepsy clinics. When people go to clinics, they think it's epilepsy, only to realize that these are somatic complaints. But usually, these symptoms are telling us that the young person is going through a lot of what? Stress. Then the common symptoms can mimic, of course, jerking or seizures, or sometimes they're going to complain of headaches, joint pains that have no medical cause. You go to the hospital, you check that person, everything, and you cannot see the cause, but the person is sick. True, they are sick, they are not pretending, but the psychological stress has converted into physical symptoms of a disease, okay? So when we are encountering these young people, let us not tell them that they are pretending, they are sick, okay? Yes. Let's continue. Now, causes, what are the causes of these somatization disorders? We've talked about psychosocial stressors, like someone who went through childhood, trauma in childhood, someone who is abused, someone with significant changes. They are frequently linked to somatization. Frequent changes can be death of a loved one, like a parent, changes in schools, and so many other stressors. If they are academic pressure, by the way, so much academic pressure that a young person cannot cope up with it, so they may begin to present with some of these problems. Then psychiatric comorbid. Comorbid means a mental health problem is happening with another problem. There are two, maybe two in one mental health issues, like people who have a lot of depression, trauma, or those who might have dissociate. Dissociate is you go out of your usual experience and view as if you are in another world, okay? Then we have family dynamics, a family where there is a lot of chaos. Dysfunctional communication. People neglect one another, overprotectiveness in family systems. Parents are overprotecting their children and they don't want anything small to happen to them. So when these children grow up and they are not able to deal with stress, they are going to struggle coping. And this can lead to these somatization problems. Yes, next slide. Then schizophrenia. Schizophrenia is one of the severe mental forms of mental health problems, where a young person, it normally begins around adolescence, early adolescence, from around maybe 11, 12, and then it goes on. But you might see that a young person is going to have hallucinations and delusions. Hallucinations, these are experiences that affect our senses, like hearing voices, seeing things that others don't see, hearing things as if they are crawling on your body, but no one sees them. And then delusions are false beliefs, where someone believes maybe I'm the president, they believe they have the powers to heal, so they have false beliefs. And then confusion, unusual thinking, like they think maybe the people are looking out for them to harm them, troubled relationships, and then abnormal motor behavior. Like sometimes you're going to find someone who has schizophrenia maybe sit in an awkward position, let's say squat, and stay there for over several hours. They're going to have disorganized speech, reduced speaking, they no longer speak a lot, poor academic performance, irritability and agitation, they are quick to anger, lack of motivation, they are no longer interested in the things they used to love, they socially withdraw from people, and then they are inattentive sometimes, and they are likely to have accidents. How do we treat these problems? Of course, we have to go to the doctor. Medications, they take medicines, but also compliance. When someone complies as a patient, the treatment outcomes are going to be good, and then also seeing a psychologist. Next slide. Then we have bipolar disorder. This is a mood disorder where someone has symptoms of depression, but also after some time, they're going to have symptoms of, we call it mania, being very excited, okay? Very energetic, and so on. So usually, they are going to have, in depression, they will have feelings of sadness or hopelessness, less interest in pleasurable activities, negative thoughts about the future, loss of energy. Insomnia is lack of sleep. Then talk about suicide or death. But when that switches, they're going to have poor concentration, easily distracted, poor appetite, weight loss. So sleeping little, if you are sleeping much, they sleep little. Racing speech, impulsiveness, they act without thinking, jumping from one idea to another, heightened sense of self-importance. There's what we call delusions of grandeur, feeling that you are a very, very important person. Okay, you are richest, you are you are on top of the world. Okay, yes. So treatment, we can give people medication, they can see a psychologist, okay, and other treatment. But what can put people at risk if you have a relative, a first-degree relative who has bipolar and periods of high stress, or people who abuse alcohol and drugs, okay? Yes. Next slide. Then we have developmental disabilities in children, young children. So developmental disabilities, this is a complex group of disorders that cause physical impairments, intellectual disabilities, speech disorders, and mental conditions. They are diagnosed at birth, but more often they are not easily identified until ages 3 to 6. Okay, so a number of these conditions can include cerebral palsy, Down syndrome. Down syndrome, I think we know it. You find this child who looks like a Chinese, but is a Ugandan. And you go to another district and you think you've seen a brother. You go to Gulu, you go where, and they more or less look like the same. Small eyes, round head, short fingers, big tongue, okay? You've seen those children. Then there are other genetic conditions like Fragile X syndrome, fetal alcohol syndrome, and drug-related syndrome, especially when mothers abuse drugs. Children are going to be affected while in the womb. Intellectual disabilities, then spinal bifida, the spine, the neural tube in the spine does not close properly when the child is developing. So when the child is born, it has a bulge behind, okay? And it requires surgery, especially women who may not take folic acid. So it's important for women to have antenatal visits to avoid that. Tourette's syndrome is some form of neurological kind of problem. Let's continue. Next slide. Now, risk factors for mental and developmental disorders in children. I got this table, which was interesting, which can look at lifelong problems like natural disasters, physical illnesses, malnutrition, illness also of caregivers, exposure to trauma, adversity, violence or conflict, genetic background, toxins, immigrant status. These risk factors can affect someone lifelong from childhood. Then at preconception, before when a woman is conceiving unwanted pregnancy, inadequate spacing of children, adolescent pregnancy, and then consanguinity. Then prenatal and perinatal issues, inadequate prenatal care if you're a mother and then you don't have adequate care, complications during pregnancy, maternal cigarette and alcohol use. Then during the womb, pesticides enter the womb and other toxins. Then during birth, which we call birth hypoxia, the child delays to breathe, or any other complications during birth. Then maternal difficulties adapting to pregnancy or arrival on a newborn. There are some mothers who produce children and they cannot care for them properly. Perinatal maternal mortality, when the mother also dies. Then infancy or early childhood, maternal mental illness. If a mother has mental illness, it's going to have an impact on the child. A child who is not allowed to play, always closed in the house, they don't grow well. Then inadequate parenting, developmental and behavioral problems. Then family, peer and school problems, school-age children. If someone has issues with family, peer or school problems, then maternal mental illness, bullying, inadequate parenting, inadequacy of schools or teachers. If teachers are not supportive enough and of the learners, then developmental and behavioral problems, then risk-taking behavior such as alcoholism, drug use, and so on. Then in adolescence, we can have family, peers or inadequate parenting, developmental and behavioral problems, maternal mental illness, substance misuse, early sexual activity, risk-taking behaviors, and then school problems. So those are the ones that can put children and adolescents at risk of mental health problems and developmental disorders. Next slide. Then conduct disorder. I think you've seen these children who are very rebellious at school, okay? Where a child persistently has emotional and behavioral problems that they're antisocial and aren't age appropriate. Sometimes they're going to be aggressive, they intimidate or bully others, they physically harm people or animals on purpose, they use weapons like knives, some on campuses in schools, they often initiate physical fights, then they lie a lot, lying, breaking and entering, stealing, forgery, then destructive conduct behavior where they can deliberately set a fire, especially some children who might lead strikes, okay? Then damage to other people's property intentionally, other intentional destruction of property. Then violation of rules, like they can skip school, which we call truancy, eloping from home, they leave home and never come for several days. They can use drugs and alcohol, sexual behavior at a very young age, okay? They can engage in sexual activity. If they are boys, they can even start buying prostitutes. If they are girls, they can enter prostitution or sleep with older men, just like that. So they can violate normal rules of society. Continue. Yeah, so risk factors for conduct disorder, most especially male, then living in urban like ghettos, then where there is poverty, a family history of conduct. If there's been a family history of conduct among the parents or relatives, family history of mental illness among the parents, they're having other associated mental health problems, like we shall look at substance abuse, we shall look at attention deficit hyperactivity disorder. Parents with alcohol or drug addiction, a home that is very disorganized and dysfunctional, where there is no parenting rules, history of experiencing trauma, and being abused or neglected as a child, okay? Then treatment, we can use behavioral applications, anger management, stress management, social skills training, special education programs. You can even train parents on how to manage their children, multisystemic therapy, and many other treatments, medication in case they have any other coexisting problem. Next slide. Then we have what we call general learning disabilities or difficulties. Initially, people used to call them mental retardation, but the times have changed. We now call them general learning disabilities. Children who cannot learn, communicate, understand, all those things as well as the majority of the children of the same age in all areas of functioning. And this can vary. There are those who are profound. Sometimes we measure what we call IQ, intelligence quotient, of less than 50. Individuals who will require total care throughout life, bathing, dressing, toilet hygiene, they require support. Then we have mild, who can learn to speak and care for themselves, but will always need supervision, okay? They cannot, they can somehow live independently with adults, but they may require some supervision. Then we have those who are borderline, can normally be educated in mainstream schools with some level of support. Next slide. Then we have general learning disability issues for assessment, delayed development of language. If you look at a child as a teacher or as a parent, where they have delayed to acquire language and cannot communicate their needs, that can be a red flag. Then easily frustrated. If a child has a low self-esteem, children may also have epilepsy or physical problems, attention deficit hyperactivity, behavioral problems. Physical or mental illness may not be obvious, but parents may be distressed and unable to manage the child. Then there's lack of stimulation or proper education, like the child has been denied play or schooling. Then the child has been neglected, physical or sexual abuse. Then we have bullying, rejection, and abandonment. Or siblings can be ashamed or over-involved in care. Like a sibling does not want to associate with his sister or brother who has a learning disability, or they overly commit and defend them. They always be where they are to try to support them. Okay. Next slide. Then we have what we call specific learning disability, a child of normal intelligence who has difficulties in one of the more aspects of learning so that they can underachieve at school. Some of these, the children who have what we call specific learning disabilities, they are normally intelligent, but they have something that may affect them, okay? Sometimes they may require additional educational help, or they require help for emotional or behavioral problems, including treatment for some condition called attention deficit disorder. So the signs can include problems with reading, writing, or arithmetic, understanding or following instructions, remembering what has been told, telling left from right, reversing letters and numbers. They are clumsy, cannot use a pencil, they cannot tie shoelaces, they have a poor sense of time. So these children can have what we call specific learning disability. An example is a condition called dyslexia, which affects reading, writing, or arithmetic, or even positioning of the letters. So these problems can be easily recognized and then you can refer. Next. Then we have even those of language where significant delay in the development of language, where children cannot express language, they cannot comprehend, they lack the ability to follow normal conversation. The meaning, there's what we call semantic, pragmatic disorder, like they they struggle to follow and understand the meanings or the semantics in the communication. May be associated with autism or ADHD. Once language has developed, the child can continue to have problems even learning and may have poor comprehension, cannot follow instructions. They frequently show behavior problems because of frustration. Like others can always tease them and usually they end up fighting. They often have problems relating with other children. They need speech therapy, special education, extra help in school, and they may require treatment for associated other mental health issues. Continue, next slide. Then we have autism spectrum disorder. Autism, this is a neurological disorder that affects children's abilities to engage in communication, social interaction, and even with others, and they tend to have what we call repetitive behaviors, okay? So they may even avoid eye contact. For them to function, they need to depend on a routine. And these children, they may have difficulty expressing their feelings or emotions, okay? So this condition can make academic skills difficult, okay? They cannot solve problems, they cannot write, they cannot concentrate. Sometimes they're going to lack social skills on how to relate with other classmates. They have difficulty transferring skills they have learned, let's say from a classroom, into a real life situation. Then they have sensory sensitivity. They can be unusually responsive to lights, sounds, smells, or touch. Like when you put in a light, let's say you are in class, the light might irritate them. Sometimes certain noises can irritate them, and you may see them touching their ears to block the sounds, and even changes, transitions. If you change a caregiver, or if you change their routine, they usually struggle to cope. And then they have restricted range of interests, okay? Continue. So the features of autism, we have social impairment, reduced eye contact, interest in people or relationship, unable to recognize people's emotions, communication impairment, delayed or abnormal language, use of personal pronouns. Echolalia is repeating the same statement over and over again, unable to point, restricted repetitive activities and interests, hard or spinning objects, lining up toys, maps, insects, special talents, and so on. Generalized learning disability is present in a number of people with autism, okay? Yes. Let's continue. Next slide. So what changes can we make as educators? Make your classroom autism friendly, where you can maybe adjust for light, sound, smells, touch, anticipate problematic behavior. Sometimes if you've worked with a child for some time, you know what triggers unwanted behavior in a child so that you remove that away in that environment. So provide you visual supports, like have a clear visual schedule where you put activity and then you put a picture so that they can learn how the schedule falls. Then some people can use technology to support them in academics. And then sometimes for directions, they can use maps or pictures with written words. Next slide. Of course, these are the supports for autism, program for infants, speech therapy, sensory integration therapy, physical therapy, hearing impairment services, family training, social skills training. For school and students care centers, social special education services, transition services from one setting to another, speech services, behavior challenges. Adult homes, adult living skills, communal living skills, emotional behavior management. So for day activity or care centers for adults, we can look at how they can participate in mild exercise, learning basic or practical living skills, socialize with members of their community. Next slide. We have what we call attention deficit disorder or attention deficit hyperactivity disorder, ADHD. So this one affects 1 to 5 in every 100 children. So which means it's more common, more boys than girls. So in your school or any community, when you see a child who is overreactive or hyperactive, they fidget and interrupt others, they have poor concentration, they are easily distracted, they are impulsive, they show problems with learning, but often have normal intelligence. They have problems at school and at home. Then you might think about attention deficit disorder. Next. Next slide. How do we recognize ADHD? Of course, we look at patterns of behavior which has been present since a toddler. When someone has been a toddler, from around 2.5 to 3 years, okay? A child's behavior and concentration does not improve as they develop. So they stand out more than other children. You go as they finish nursery, maybe around top, you see that they are still struggling with concentration. They cannot settle. But sometimes we can ask for their developmental history, the views of parents and teachers, what teachers tell us about this child, then the behavior similar at home and at school. And sometimes we can even look at checklists to see the behavior as well as observation. Next. Then, of course, common presentations are those. I think they will, Mr. Stephen will share with you the slides. I think we can go to the next slide. Ways to help the child, we can use behavior principles where we can help kids get organized and replace negative behaviors with positive ones. Some of them, they may require medicine to reduce the symptoms, especially if they are very active. But also we can make some classroom accommodations. Like a child with ADHD might require to sit in front of the classroom, away from the window. Sometimes even when they are doing tests, you can add them more time, okay? Yes. And then we give things in short breaks so that they can finish them rather than giving them long periods because they lack concentration. Next slide. Then associated problems of attention deficit can be speech delay, specific learning problems, clumsiness, sleep problems, other developmental problems, e.g. autism, learning disability. Then often develop problems with learning and underachievement. They have a low self-esteem. They have problems with friendships. They have temper tantrums and difficult behavior, and they end up being excluded from what? From schooling. Next slide. Next slide, okay. Then we have post-traumatic stress disorder in children and teenagers. Anyone who has been exposed to a very terrifying event, whether they narrowly survived the death or even if they were abducted and taken by a ransom, or you are put at a gunpoint, or you witness another person die in an accident. So those memories can be very severe and be very difficult to deal with. And they can commonly bring about a lot of fear and anxiety. So they are going to have nightmares. They are going to have sleep problems, which we call insomnia. They are easily angered or increased irritability. They withdraw from friends and loved ones, and as well as activities. They have difficulty with school and concentrating, and then they are more likely to have depression. Okay, so if these symptoms happen for a period of 1 month, then we can think about post-traumatic stress disorder. Next. We can help By spending time with these people, we can encourage them to end up to do exercise. Then they seek for counseling. Then they can make some lifestyle changes. Then they can do some journaling, writing down your thoughts. Usually it helps to declutter your mind. And then mindfulness is a form of meditation and allows people to tune into their thoughts and control them without really allowing those thoughts to control them. Next. Then we have, of course, children who are likely to suffer PTSD might include those who have been abused, sexual abuse, emotional abuse, neglect, domestic violence, or a combination of those. But now sometimes we look at the time factor and scale. But then also we have child abuse and neglect itself, okay? And then we need to ask by whom and in whose care. Sometimes as parents and teachers, we fail to protect our children, and then we are going to end up abusing them. Next. Now, emotional abuse and neglect, we have history, what the child says if you want to assess emotional abuse. Sometimes what children tell us, interaction with parents or caregivers, siblings, and then neglect. Also, we need to look at what children tell us. Sometimes there could be poor home conditions, emotions and behavior problems, then, and how this affects development. Emotional abuse and neglect are pervasive, and actually they can affect the child for a very long period of time, okay, including their development and relationship. If you've been abused as a child and neglected, even the quality of your relationships, if intervention is not done in future, you might struggle in those areas. Features of emotional abuse and neglect, there can be language delay, low self-esteem, academic failure, poor peer relationships, behavior problems, and then poor school attendance. Next slide. Then physical and sexual abuse. Sometimes physical abuse, injuries, what a child has said, a child who is always being watchful, looking over their shoulder, or lack of response to conflict and aggression and behavior, that might indicate someone who is who has experienced physical abuse. And of course, sexual abuse, what a child has said, someone who has been sexually abused as a young child, they may struggle with enuresis, they may fail to hold their urine, or they may fail to hold their fecal matter because someone has forced them into a sexual activity. Then sometimes they have a low self-esteem, depression, they have specific fears, like the perpetrators might always instill fear in them, not to talk about the act, and behavior or sexualized behavior. If a young child is displaying sexualized behaviors among others, you might suspect sexual abuse, masturbation, running away, eating disorders, substance misuse, an adolescent who might want to self-harm, suicide, and also if there's a family history of what? Sexual abuse, all those can indicate to us. Next slide. Then substance abuse among children and adolescents. We know that this is now a big issue in the country. So it is widespread, especially alcohol abuse. And research has shown us that approximately 39% or 40 of children ranging from 6 to 17 in Uganda have consumed alcohol at least once, and almost 27 report recent use. That means that there's a growing number of young people, children and adolescents, who are using substances. Then in urban areas like Kampala, you find that almost 35% of adolescents have used drugs And then 16% have been identified as high-risk alcohol users, people who drink excessively, people who use these drugs in very high amounts. So the use of tobacco, cannabis, and cat is Mairungi, is more common among youth, being influenced by peers and then environmental factors. Continue. Causes and risk factors of substance use or abuse. We have poverty and unemployment, where poverty drives children into environments where drug use is normalized, like ghettos. Lack of unemployment prospects, which may fuel escapism. So if I'm bored, I might use drugs to escape from that from the reality of that frustration. So I become an addict. Then we have peer influence and social exposure. Youth often mimic peers who use drugs, especially in schools and slums, with minimal adult supervision. So some youth might mimic others because of peer pressure, but of course also social exposure, social media, some of these idols we see, musicians and so forth, they influence young people. So young people use drugs because of these idols they have. Then family neglect and abuse. Children from abusive or neglected homes are more likely to engage in substance use as a coping mechanism. Okay? Yes, so from broken homes, children are more likely to, because they are coping to stress and other challenges. Next slide. The consequences of substance abuse in Uganda. Now we look at the impact on health, education, and future prospects. Of course, the consequences, one, we have mental and physical health decline. Substance abuse leads to depression, anxiety, liver damage, and other chronic health conditions. Okay? Which might require surgery, or sometimes people die because of these complications like cancer, liver of the stomach, liver of the cancer, liver of the, they suffer from many conditions. Then education disruption. Of course, young people addicted to drugs show higher absenteeism at school, poor academic performance, and then dropout rates. I usually tell educators that if you see a learner declining in their academic performance, please go and dig more. Sometimes it might be drugs, but then there are other factors. Then there is increased criminality and social isolation. Drug abuse is linked to juvenile delinquency, violence, and then future marginalization. Okay. Next slide. Now, how can we promote and prevent, how can we promote mental health and maybe prevent mental illness? One, we have to build individual capital for mental health. That is competency, resilience, and then empowerment. So we have to create networks of people where we support one another, especially during difficult times, okay? So that people can easily cope up to challenges. Then the next one is promoting healthy behaviors, exercise, diet, good sleep, not indulging in drugs and alcohol. Then the next one is building social resources for mental health, or creating opportunities to positive relationships and social support at different levels. So having good relationships among members, starting from the families, among peers, and among even the community. This can promote our mental health. Next slide. Supporting people at risk through selective prevention, especially people at risk in the community. Young people, women, even the elderly, youth, okay? So these are people can be at risk. So we can select those at risk populations and then put programs in place to prevent them from getting into situations that can break them down. Then preventing mental health conditions through indicated interventions, like creating awareness, people learn about these problems and what they can do to reduce the burden of these issues. Then protecting and promoting child and adolescent mental health through policy and through policies and legislation. We can even form caregiver groups, school-based programs for mental health, and then environments outside the school that can all support mental health. Next slide. Next slide, please. When you look at that picture, can you identify a learner who can be having an issue? If you looked at that picture, the teacher is in the classroom, but as someone who looks at that picture, do you see a learner who could be having an issue? Members are quiet. Do we see any learner who could be having an issue?
Maybe we can ask them to raise their hand, maybe, but
Okay,
you can as well.
Or even you can put a chart and describe that child in the chat.
Those who can, you can even write on the screen and maybe circle the learner. Okay. Mr. Samuel, have you been able to see? Mr. Muhinda has circled
Yes, someone has
that.
circled that. Yes, yeah, sure. That learner there seems to be having issues. There's a one holding the chin, and the face looks a little sad. Other learners are busy concentrating in their books, but her mind seems to be elsewhere, okay? So some of these, and young people usually don't communicate, but you see a change in behavior. And for us, we believe behavior is communication. Behavior tells us something about a child, okay? So it's important to take note of these as educators, okay? Or even parents. Your child is isolated from their siblings. They want to lock in their rooms all the time, okay? Yes. They are oversleeping. So these are some of the behaviors that can be indicators, okay, of someone struggling. Next picture. As teachers, break time. Spend some time and observe your learners as they play, break lunch time. Clearly, you may see learners with what? With issues, okay? Isolated, sitting alone, sad, okay? Others are playing, but for them they are. When they go for lunch, for them they stay in the class and put their heads on the desk, okay? Or sometimes it can be that they like to initiate fights and fight a lot, okay? So all of those could be some of these behaviors that we can see. So next slide. So now what can we do? We can have what we call school mental health programs. We can promote mental health in school settings and implement some strategies to promote, protect, and even restore mental health among students. And we can achieve this by supporting children's social and emotional development, teaching them to talk about their feelings, okay? Allowing them to sit in groups and share, okay? Then promoting mental health and well-being at all levels, not only young children, but from kindergarten to on until maybe higher levels of learning. providing age-appropriate behavior management, depending on the age, what is the expected level of behavior, and how can we train young ones to manage behavior. For young children, it might be different from adolescents. Then identifying and address early signs and symptoms of mental health conditions. For some of these conditions we've seen, we can identify them. And when we identify, we can call in the parents, and then we discuss maybe to refer to a counselor, the hospital, where they can get support. Next. This is a sample of a school mental health program that addresses learning goal and then intervention. So you see, they are all around, from emotional to cognitive to social to physical, okay? And then there are goals there: emotional regulation, stress management, mindfulness. That caters to emotional. Then the cognitive looks at problem solving, drug and alcohol knowledge. Then social, interpersonal skills, assertiveness, okay? And then physical, look at exercise or physical activity. And then the interventions are there, which you can implement for learners. Next slide. Then even for us teachers, we need to talk about mental health. How we can raise awareness about mental health to even the learners in schools. We can prevent stigma and discrimination. Some of the learners can be stigmatized by others, but as teachers, we can come in and support this learner and protect them from being stigmatized. We can promote a healthy lifestyle and work-life balance. For example, we teachers, some of us, we want to make ends meet in the Uganda of today, but also you should prioritize your mental health. You teach in I don't know how many schools, okay? These days, there's a term they use, okay? You hustle, but in the process, you forget, okay, about your own health. You've acquired a lot of stress, and this is going to affect you, okay? Then we can support ourselves. Some of our colleagues, I've seen some teachers actually, who have had some of these mental health issues, and they need support from us. Not gossiping about them, not firing them to leave the school, because they have the potential. We only need to support them so that they can be the best version of themselves. And then facilitate access to mental health services. We can also link them to other services where they can get mental health services like medication, counseling, and so on. Next. Now, this is going to be our discussion. I don't know how much time, moderator, we have, but I wanted us to get into discussion to just brainstorm. How can we promote mental health in our educational institutions, in our schools? What are some of the things? There may not be big things, but what can you do every day to see that you promote the mental health of your learners, even including yourself, because you are part of the school community? Even for us parents, I know there are parents on this platform, but how can we promote the mental health in our educational institutions? Yes.
Okay, you can, let me maybe first stop sharing. You may raise up your hand, or you can unmute and you share with us.
Okay.
Hello, I am called Flavia. I'm not a teacher, but I would want to contribute and say that for students in schools, Maybe on our notes boards, we can put something about mental health, and we can always talk about it in assemblies, or if we have maybe those classes where they teach about health and what we can be able to talk about them. We can have also a counselor in a school that students, learners can be able to approach. I also think they should also be those what are they called? Posters, the ones they put all over in maybe the compound that talk about mental health. So that every time the students, the learners within the compound, they have access to the information. That's all I wanted to share. Thanks.
Okay, thank you so much, Mrs. Flavia. Someone in the chat has also shared, Mr. Henry, and is saying regular exercises, programs to promote good physical health and mood. Thank you, Mr. Henry. Feel free to unmute and then make your submission. Okay, Mrs. Juliet, she's saying, in my workplace, we encourage students to take up at least a sport. We share quotations on notes boards. We have life skills sessions for psychoeducation. We have introduced wellness sessions like Zumba and swimming for both learners and teachers. Thank you so much, Mrs. Juliet. Any other that wants to share how we can promote mental health in education institutions? Okay. Mr. Samuel, I think those are the ones who have been able to share.
Yes,
okay.
Doctor. This is Jalia.
Okay.
Hello.
Yes. Yes, kindly go on, Mrs. Jalia.
This is Jalia. The question is, how can we promote mental health in educational institutions? So I would say that I can integrate mental health in curriculum integration. So we can integrate mental health lessons under curriculum implementation by allowing the teachers to start their lessons and ending their lesson by talking about mental health activities, signs and symptoms. Then secondly, we can talk about mental health first aid, empowering these learners to come up with the first aid treatment about their health. Those are the immediate interventions. Then we can also apply public awareness campaigns, whereby you can call in the community, that is public relations, talking about the mental health. Then that is so that I can submit.
Thank you so much for sharing. In the chat, Mr. Solomon, engaging parents in children behaviors in order to help them come out of stress they go through. Another person has shared and said through prayers and Bible quotations. Mr. Arthur, we can encourage open communications, promote academic balance, monitor and address bullying. Then Mrs. Esther, having mental health talk shows. Then Mr. Teacher Amos, according to my understanding of this mental health, can be promoted through organizing regular class meetings, which can make learners to share their problems. Mr. Arthur, providing training and resources. Okay, thank you so much, everyone, for sharing. And over to you, Mr. Samuel. Okay, then the last one, Mr. Yusuf. At my school, we have chosen different. Yes, you can go on.
Good afternoon, everyone. I'm
Good
not
afternoon.
a teacher, and I'm also not a parent. I'm a university student at Lira University, pursuing a Bachelor of Science in Community Psychology and Psychotherapy. For me, what I can say about promoting mental health in schools, there is this important point I think we should all think about. You know, the academic pressures in school, let's always encourage students to have enough sleep. Students are not sleeping because they want to perform very well. And we all know the importance of sleep. So usually, you know, schools be having tight schedules all day, preps going up to 10 p.m., but students carry on with reading up to even 1 p.m., 2, which is not really good on their mental health. So they need to sleep. And then as the previous presenter already said, most people, including staff members and the directors and they need to be sensitized every now and then. Some of them don't think about this mental health to be so important. So staff training can also be incorporated in their activities, such that when they can even host talk like speakers on mental health, such that they understand how some of their students can be handled. Usually some students present with these mental health issues, and you find some teachers beating them because they do not know that it is a mental health issue. Yeah, so and then as we know, stress is also one of the biggest mental health issues, and it usually surfaces during times of exams and so during those times you can incorporate in stress and stress management activities, train students on these simple skills, the breathing techniques, such that they can reduce on the stress and the anxiety, because they be anxious fearing the exam and whatnot. I think that is what I have to say. Thank you so much for your time.
Okay, thank you so much for sharing.
Yes,
In the chat,
Doctor, I have a supplement.
Okay.
I have a supplement, Doctor. First and foremost, I did not introduce myself. My name is Nanyango Jalia Kasasa, head teacher for Umeya Primary School, and a student in the University Kampala campus, pursuing a degree, pursuing masters of arts in education, curriculum and instruction. So my supplement is we can also promote positive relationship in these learners. So everything can be positive instead of negative essence. And also we can promote culture of openness. When the children get the open activities and the active, they can easily come up with the interventions on mental health. And second last, we have to support around the mental health. There are some administrators who cannot even put in much incentives to support these learners with mental health, but it is mandatory for administrator to work upon this area. That's where I talked about the first aid. Then lastly, we can provide access to counseling and support services. I beg to submit, Doctor.
Okay, thank you so much, everyone, for sharing. In the chat, Mr. Moses is saying that by hiring mental health professionals, Mr. Arthur provides support service, promotes healthy lifestyles, fosters supportive environment. Mr. Moses integrate it into the education curriculum. Mr. Andrew, I just advise that we need to consult occupational therapists. These are the health professional experts in autism and ADHD management. Then Mr. Yusuf, at my school, we have chosen different days to do aerobics using some music to stimulate learners, and as the teachers have our day starting from 4 p.m. to 5 p.m. Okay, thank you. And over to you, Mr. Samuel.
Yeah, thank you, Stephen, and thank you all for your submissions. Actually, when I see these, I was just smiling when I read these comments. Sometimes you don't need to do something very big to promote the mental health of a learner. Sometimes you can even have what we call circle time, where you allow learners to sit in a circle, talk about different things, challenges. Let's say someone talked about sleep. What affects our sleep? How can we improve our sleep? Or do you find yourself sad? What makes us sad? And these young people are going to talk about the issues. Some of them come from homes where they come from, and they're affecting them. They are impacting their academic function or learning. So then you worry, okay? Then maybe this is also subject for discussion. What I've noticed in many schools, we've seen about something to do with substance abuse. When a learner is maybe a group of learners identified as substance abusers, in most schools, the only thing they do is maybe to expel these learners. But do we really understand why young people take drugs? Maybe if we sat down to understand why are they taking drugs, it could be an effective way of coping to family violence, a problem somewhere, somehow. Okay? So sometimes it's important to understand some of these problems that young people go through. And that is why they present themselves as maladaptive behaviors. Yeah? Like I said, behavior is communication. Most young people are not confident enough to come and talk to us as educators. They are not comfortable to talk to even parents. And some part of the reason has been the way we associate with them. The first day you come in as a teacher, you show to these young learners that you are feared, okay? Instead, you could show them that you are respected so that they come in, they are free to talk to you about their issues. But when you create an environment of fear around you, young people are always going to hold back. In my practice, when I see young people, I always ask them, you have this issue, do you have a school counselor? Do you have a senior woman teacher in your school? They say yes. Why don't you go and talk to them? They simply say we don't trust them, okay? Or we fear them. Or some of us, even when some learners come and talk to us, we cannot uphold confidentiality. So how are we supposed to support them and get to know if we cannot create an environment where we build trust, where they can trust us and not fear us and come and share with us what they go through so that we can be able to support them, okay? These are some of the things that we can do to support. Or even a problem is coming from home, can we follow up with the parents to find out what is happening? Some of these learners that I've interfaced with, they have always said, yes, I perform poorly, but my issue is coming from home. Maybe I live with one of the parents who is very abusive, okay? And I'm in depression. and that's why I cannot focus or concentrate in class. Okay? Yes. And sometimes we may also punish poor performers or non-performers. And this will further affect the learner. So sometimes it's important to create a culture where learners are free to approach you when they have an issue to talk about. And these are some of the small things that we can cultivate within the school culture and so on. Okay, so I think we can continue. How many slides are we remaining with? So, okay, just the one slide. Oh, okay. Now, in conclusion, mental health is very critical. There is no health without mental health. It is very vital part of our overall health. And it can affect us in many ways if we don't take care of it. Because without mental health, you cannot function. You cannot thrive as individuals. Okay? Families and communities. Our mental health, if well supported, it helps us to cope. There are so many challenges we face as people. Learners need to be taught, learners need to be sure that in life they are going to face so many stressors, but we need to help them to build resilience, to face these challenges without getting in a position where they are overwhelmed by them. Okay? Yes. We can have programs. I've had teachers here talk about programs in schools, life skills. Okay? Teach them life skills. Yeah, it's good to have marks, but at some point, everything has a limitation. Sometimes it is these life skills that are going to set a learner apart from the rest. So we need to help them to develop life skills, communication skills, building resilience, conflict resolution, managing stress, and so on and so on, being assertive. All these things are going to help them somewhere, somehow, as they grow up as leaders of tomorrow. Okay? So mental health and access to mental health are a basic human right. It is a right to access mental health. There is no shame. The only shame would be if someone gets worse and has not received the mental health service. But mental health service, the government of Uganda has included actually it in the minimum healthcare package, at least from a health center, 3 or 4. There is a primary mental health work, at least a psychiatric nurse. Then the health center 4, maybe you can find a clinical officer or regional referral hospital, at least mental health. And even these days, we are trying now to reach out to the educators to train you so that you can be able to identify and offer basic mental health and psychosocial support. Where you identify a learner that is severe, then you can refer to the experts so that they can get the support that they need. I would like to end here unless members have questions. I'm willing to take questions if there is still time. Thank you very much.
Thank you so much, Mr. Samuel, for the wonderful presentation. For the members who have questions, kindly raise up or you can unmute yourself and then pose your question. Okay. Maybe I saw some questions that came in early. Mr. Okelo was asking, what happens on someone's mind and emotions or the whole brain system to commit suicide?
Oh, okay. Now we look at on suicide or self-harm. Usually we look at what puts people at risk. One, we look at people's age. Okay, young people are more likely to commit suicide. Then we look at things like, has someone had previous attempts? If someone has ever attempted suicide, they are more likely to commit suicide. Then someone is taking alcohol or drugs, they are more likely to commit suicide. If someone lacks social support, someone has a problem and they have no one to turn to, they are more likely to commit suicide. Then people with acute emotional distress, a sudden acute emotional distress, someone can commit suicide. Yeah. Then we can look at if someone has a mental health problem, particularly depression, severe depression, people can think about committing suicide. Then there could be rational thinking loss. If someone no longer sees a future, they have been suffering and they no longer see a future, they will be thinking, I think the best thing to do is let me die, okay? And I stop this suffering, okay? So those are some of the factors that we can look at that can put people at committing suicide. Yes, thank you.
Thank you so much. Another one is asking, how can we handle students who are mentally disturbed in class? Such students are off and on. Then the second one, in the same direction, why some people oversleep whenever they go to bed, they immediately go off until morning?
Okay. Now, of course, if you identify a learner with a health problem, the first thing to do, a mental health problem, the first thing to do, you could call the learner and try to speak to them in a gentle manner and understand their struggles, what they are going through. If you see that maybe they are in a state that is severe, that they cannot maybe initiate a conversation and so on, using your systems, call the parents or the guardians that are concerned and explain, okay, your observations and recommend that they visit a hospital. They go and see a mental health worker so that they have the person checked out, okay, to see if they have a problem so that this person can be treated. But usually approach the learner with empathy, be more available to listen what they talk. Do not judge the person, okay? Do not discriminate, do not stigmatize, okay? Show them that you're concerned and you're willing to do what? To support, okay? Yes. Then sleep, of course, I've not mentioned the other mental disorders, but we also have sleep disorders. But sleep can be also a symptom in many other disorders, either too much sleep or a lack of it, or a reduced sleep ability can be a signal for a particular mental disorder. For example, in depression, people can have sleep changes. They sleep a lot more than usual or less than usual because of too much worry or thinking, okay? But also, too much sleep can be, maybe people have sleep problems, sleep disorders, and at this case, too much sleep, they need to see a psychiatrist. Maybe there is a problem with their brain, but too much sleep can be also depression, like I've said. Or we work in environments that have a lot of stress. So people are having what we call chronic exhaustion, chronic burnt out. When they go to sleep, they sleep so much. But if this is a concern and it's affecting the learner, then we need to refer them to a specialist to have them examined. Okay? Then we have other sleeping problems like sleepwalking. A person wakes up in the middle of their sleep and they are walking and as if they are possessed. But then by the time they tell them the next day, they cannot remember. Then there is sleep talking, people who talk in their sleep. So all these are problems with the brain. But sometimes some of these things come due to mental health problems like trauma, or severe anxiety. So we might be able, or severe stress. So we might be able to refer these people to have them checked out. Yeah, thank you.
Well, okay, thank you so much, Mr. Samuel. Another one is saying, what is a vivid, good, precise definition of autism? Part B, can autism be prevented at a rate of birth? 3,
Okay.
what common signs usually detected earlier with a child suffering from autism?
Okay, thank you. Now, the best way I can describe autism is normally your child will grow very well, but around 2.5, 2 to 2.5 and 3, where the child has begun language and communication, then the language begins to disappear. If the child was having eye contact, that eye contact goes. If they were reciprocating your emotions, you smile, they smile back. That may also disappear too. If they began to interact and play with other children, they now become more caged in and they want to play by themselves. So what you see is problems in communication. Okay, it will be they rarely speak or they have repeated sounds. Then social interaction is gone, and then repetitive and stereotyped behavior like hand flapping. Okay, they have those mannerisms of making their hands, okay, repeatedly. So that is the classic definition. So the age of onset is around 2.5, 3, when language development had started, but then it disappears. Then there are certain things we can do to prevent it. Literature has shown that if some people with some mental disorders may produce children with autism. For example, people with schizophrenia are more likely to have children with autism. But also, there is a risk if you produce a child during your teenage years, early pregnancies, and also very late. I'm saying a risk. You need to quote me very right. Early pregnancies when the body is not fully matured, but also late when the body is now beginning to weaken, okay? You might produce a child who has these issues, okay? Of course, the other things we do is that you avoid produce at the right age if a woman is to have, and a man at the right age. At least for a woman, they say not above 35 is okay. For a man, they say not above 45 is also okay. Okay, but it's not exclusive. I don't want to take this as a gospel truth, but we said that it increases the risks. Okay. Then of course diet is very important. Eat well during pregnancy. If you are a woman, avoid alcohol and drugs. So those are the things that we can do to prevent some of these conditions. Some people have even gone in developed countries to do what they call genetic counseling. They go and they test your genes to see if you are going to produce a good child. Okay, but of course those are high costs. But for someone who is a layperson like us, there are certain things you can put in place as preventative measures. Okay, yes. So I don't know whether I've answered you on that.
Okay, thank you so much. Another one, who is an exceptional child amongst learners we teach?
An exceptional child. The word exceptional, I can look at it in two ways. Exceptional is one who is maybe performing outliers, okay? Someone who is extremely intelligent and high there performs better than others, or someone who tends to also perform poorly. Those I would call them as exceptional children, okay? Exception can be something unusual, okay? a person who can even skip one class and go to the next and they perform better, that is very intelligent. I will classify that as an exception. Or someone who is struggling, he needs a lot of coaching. You have to break down into, smaller components for them to learn. Sometimes in these schools, we call international schools, they even set individual education plans. Okay, the child is not going to learn normally like others. Maybe they learn more with pictures, they learn more with videos rather than notes. So such children might be exceptional. Okay, so that's how I could define that term. Okay, yes.
Okay, thank you so much. Okay, looking through the chat, I feel you have been able to exhaust all the questions. Maybe Nora, they were asking for your contact. Think your contact. Let me share the screen such that they can be able to take note of the contact. Okay, this is the contact and the email that you can be able to reach out to him for support. Okay, maybe the last one, maybe you can throw some light on communication disorders, something small.
Okay. Thank you. Now, communication disorders, this might be disorders that affect children in the way maybe they speak, articulate a language. They are what we call phonology, phonics, okay? How they articulate words, but also in communication disorders, we can have conditions like stammering or stuttering, okay? That affect learners in the ability they would express or communicate to others, okay? Yes, so sometimes there can be things to do with, like I said, phonology, semantics, understanding syntax. So, but these are not so common, but although they are there, but they're not so. But what we see mostly in schools can be stuttering or stammering, and then phonology, how people pronounce sounds. Okay, yeah, some people might make fun of others how they and they have that phonics or phonology. Okay, in those communication disorders. Yeah, yes.
Okay, thank you so much, Mr. Samuel, for responding to all the questions and then for the wonderful presentation. Dear teachers and parents, I have placed the contact in the chat and the email. You can reach out to him for more support, and even he can be able to help you. Then someone asked whether we do organize talks in schools in refugee settings. Not yet, but we do believe that when we share the knowledge, it can reach very far. But we have plans in the near future to reach out to as many schools as we can, and we shall organize as many activities to continue sensitizing the teachers, the parents, and the students, and we shall continue to offer the support we can within our means. But we shall organize. I know people in the refugee settings, they're really undergoing through a lot of challenges. But I know the Ministry of Health and Education, they're doing something to support those children, but we shall reach there. Then the members who have been asking for the material and the recording, we are going to share the recording for this session before today ends. That will be at around, it will be around around 6. Yeah, we shall have that recording shared, and always we share it on the YouTube channel of the Holistic Learning Platform. That's where we share it. And Okay, I want maybe to show you something small. So that's where you'll find that content that you need to know about, and everything we keep on doing, we shall always put it on that platform. We are going also to share the PowerPoint and share with your schools, but also you can be able to share with the teachers at your different schools, such that we can be able to expand the knowledge, but also support the children we have within our range. Then this is the YouTube channel where we share them, where we share the content. But also when you check under the playlist, you'll be able to see some of the sessions. So when you click under mental health, you'll be able to you'll be able to check out all the sessions we have been having. So we had a session last year, we had a session. So you'll be able to see all these sessions. So some of these sessions are here, and you can be able to check out such that you can keep learning more on mental health. So there's a session by Mrs. Patience, there's a session by Mrs. Juliet. So we have all the sessions here and all other sessions that Mr. Samuel has been giving us. So you can find other sessions for your learning, but also we shall post this session in the same folder for your consumption. Okay. Okay. May I invite Mrs. Patience to give her concluding remarks and then to finally close off that session. Mrs. Patience, are you on?
Yes, I'm on.
Okay.
I think I don't have much to say, but just give. I think I have done a wonderful job. Thank you, Samuel, and thank you all of you for listening and being patient until I have noticed it's been almost like an hour since we started, and people are still patiently listening in. There's quite a lot that has been shared, and I think we can tap into this YouTube channel that Teacher Stephen is talking about. And also my advice, especially to teachers, is that be friendly to these students because they are going through a lot back at home. And when they confide in you, usually when we go to school, they tell us that they don't feel free to share with the teachers because they'll then again go and discuss in the staff room. Kindly, when a student shares with you, keep the confidence, keep the confidentiality. Don't start sharing their stories because it will break them the more. And also to listen to them more because you never know, you'd be that angel that is going to help this child. Otherwise, we also have issues back home. We can look into what Samuel has talked about. I know whatever he talked about can be managed. There's nothing out of control. At least everything he has talked about, all the conditions have a solution. We should not give up. Even if it's a child back at home, even if it is autism, everything can be managed if we indulge the services of the health workers. Otherwise, thank you so much, Teacher Stephen, for organizing this. And when we get time, we shall share even more. And we shall listen to other people too, and hear, and for our mental well-being. Thank you very much.
Thank you so much and have a good evening, everyone.